Welcome, everyone. I'm Dr. John White, and I'm excited about this fair Medscape social media discussion around navigating misinformation and advancements in food allergy and anaphylaxis. And I'm joined by three experts. My very good friend, Dr. Sung Pobletti, who's the CEO of FAIR, Dr. Steve Tillis. He is the clinical professor of medicine at University of Washington, and Dr. Matt Greenhall. He is professor of pediatrics at Children's Hospital, Colorado. Thanks everyone for joining me.
Thanks for having us.
Thanks for having us.
Well, let's start off with what is the burden of food allergies? Song, how many people in the United States are affected?
This is a silent public health epidemic. More than 33 million Americans are living with life-threatening food allergies. That's a lot of people.
And you said life threatening. There's a lot of misconceptions about food allergies. One of them is it's not that serious. But what are some of these misconceptions that we have?
Food allergies, life-threatening food allergies, it's a disease and not a diet. And people that don't understand food allergies, they think we're either picky eaters or just on some kind of weird diet. But at the end of the day, it's life threatening, and a morsel of food that includes our allergens could send us into the emergency room with anaphylaxis.
Now, Steve, you and I talked beforehand, and there's really this continuum of sometimes people have food intolerance, and then on the other end, as some discussed, there's life threatening food allergies. What do folks need to understand? And this is something even as physicians that don't treat food allergies, every day or every week, sometimes get a little confused about.
And it's completely understandable because any food that every time you eat it you have symptoms of some sort is what we call an adverse food reaction, and it is important, but it's also important to keep in mind that a true food allergy is a subset of those types of reactions, and true food allergies tend to occur immediately or at least within a few minutes after eating that food and have pretty predictable symptoms. So, for example, anxiety, headache, things like that are usually not a true food allergy, but hives, wheezing, abdominal pain, vomiting, nausea, those kinds of symptoms can be much more associated with food allergy. And it really does take special training sometimes to tease this out with accuracy.
Matt, what do you find are some of the misconceptions? And even on the part of physicians, they might be confused about the role of testing. There's over the counter tests nowadays sometimes that people conflate with the same test that they get at their doctor's office. What have you been finding in your practice that listeners need to know?
Yeah, I find a lot of parents are quite surprised at how limited there is for a role for testing, that most of what we need in terms of making an accurate diagnosis comes straight from the history. Like Steve said, a well-trained allergy specialist within a couple of minutes of hearing a history can know if it's high probability or low probability that, it meets the sort of mechanism that's really going to be a true food allergy, or if it's going to be something else. The more astute ones can tease out, okay, this is happening in the setting of a viral illness, and that's why you have hives that maybe don't even itch and didn't go away. There are a number of subtleties. So most of what we need is from the history. The tests themselves, they're very good at detecting the antibody that's there. But unlike other markers, say like a cardiac troponin or something like that, just because that test is elevated, it doesn't necessarily mean that you have the disease. There are a lot of different reasons why you can have a positive test that's just clinically irrelevant. And that's honestly, we spend a lot of time trying to educate our parents. And sometimes, that doesn't always get across. And parents can be frustrated that we didn't test, or, somebody else ran this test and we're trying to undo it. So, there's a role for testing, but it's probably more limited than I think people might realize.
And
Another
I would say,
misconception.
sorry to
Go ahead.
interrupt, but I wanted to just say one way to to sort of validate what Matt said is to remember there is no hemoglobin A1C for food allergy. I mean, I think that's something people can understand, that it is very difficult to hang your hat on one, especially a blood test.
Now, patients will come in, and I've had patients come in and they say, test me for everything, right? It's to your point, Matt, right? It's also about what are the symptoms? What's the
Right.
history? That's equally as important.
Right.
And I wanted to ask Sung, because what I often hear from parents, and maybe all of you can chime in on this, they'll say, I never saw food allergies when I was growing up. I never knew anyone that was allergic. Like what's going on? What what do we need to inform, you know, patients, parents, and even our clinical colleagues? Why are we seeing so many more allergies, or why does it seem like we're seeing more allergies now? Is there something that we're doing wrong as parents, and we should be introducing food sooner? Are we just doing more diagnostic tests? Are we more sensitive? Is it the food supply chain? What's happening here?
From a statistical standpoint, I can tell you with CDC analysis, just the amount of food allergies that has increased year over year. And it's been doing this for decades by even 50%. If you look at data from 1997 to 2011, 50% increase. And again, by 50% between 2007 and 2021. So we know that food allergies are on the rise. And if you look at it from an emergency room standpoint, there was more than 3.4 million hospital ER visits related to food allergies. So
Okay.
think about that in terms of size. That's the entire population of
What's the
Oklahoma.
cause of it, Matt or Steve? Do we know?
I'm interested to hear Steve's thoughts.
Well, I do know. I'll start out, okay, and I'll first of all validate Sung's statement anecdotally that in my practice, which started over 30 years ago, I would see peanut allergy once a week or so, and in the past 10 years, it's been a half dozen times a day in a full clinic. So it's been a dramatic increase. And I will also say I really worried that I personally may have inadvertently caused peanut allergy in several hundred children over the years because our uh, and then I'll transition to Matt to explain why. But we were counseling high risk patients, that is, patients who have either a history of egg allergy or moderate to severe eczema early in life as infants. We were counseling them to withhold allergenic foods like peanuts and tree nuts until age 3. We now know that it is completely wrong, and that's why I feel like guilty about this over the years. But I'll let Matt explain the mechanisms for all this.
Yeah, I mean, I think you're seeing a multifactorial rise. There's no one cause. I mean, some of it goes back to detection. There's a little inflation because tests are easily accessible, and like you said, you can get them in a number of different ways. So there's definitely some noise on the signal, but there's absolutely an increase in this. Some of them have larger consequence than others. There are a number of reactions that do end up requiring emergency room care, and why it's happening is, again, a number of different things. We've come up with some strategies now to potentially reduce the risk of developing, like Steve had said, for years for years there wasn't guidance, and then all of a sudden for a couple of years there was guidance that said maybe if you delay introduction in certain kids, it may be helpful. But that proved maybe to be tilting the risk in the opposite direction than we wanted. More recent data, not just for peanut, but for egg, and really limited harm, and actually zero harm in doing this for other allergens, is the earlier that it's introduced, as soon as the child is developmentally appropriate to be able to tolerate solids, the earlier it goes in, the better it is in terms of reducing the risk versus prolonged delayed. So our most recent document, I was the senior author on this and did the methodology for it, from the American Academy of Allergy, Asthma, and Immunology, the American College of Allergy, Asthma, and Immunology, and the Canadian Society of Allergy and Clinical Immunology. we're now recommending that, around 6, but not before months when the baby is developmentally ready, to start introducing foods. There's no advantage to withholding. Things like peanut and egg have the highest evidence that introducing those early, especially in certain risk kids, versus delaying it, will decrease the chances that you develop food allergy. Now, unfortunately, it doesn't eliminate it outright, but again, relative to one strategy, this is something that can help. That's about the best we can do right now. But that alone is unlikely to be the only thing, and there needs to be more research looking at other combinations and other things that can help sort of tilt the risk in a more favorable way.
So I want to go back to your point at the beginning. I love when you said it's not diet. This isn't about picky eating. What are the strategies that we need to utilize to counter this misinformation? And what's the role of the healthcare team? It's not just the pediatrician, the physicians, the allergists, the internists.
John, I'm going to pivot and just add to what Matt and Steve said because I'm really passionate about the whole notion that food allergies is increasing and this is a silent epidemic. If you think about the fact that 15% of food allergy diagnosis happens from an adult onset, obviously, this is a disease of the immune system, and we've got to invest in research dollars specific to food allergies to answer these key questions.
Well, it's a good point to raise that we've had some good research in the last few years in terms of some new medications, in terms of how we think and treat food allergies, even in terms of the way that we deliver these medications, such as epinephrine. Steve and Matt, I wanted you to talk a little bit about this evolving landscape for food allergies.
I think it's interesting to watch. I mean, this epidemic, which is, I think, in my experience, become the number one unmet need in the specialty of allergy immunology, has been without innovation for a long time, up until recently. Several years ago, the first treatment was approved. It was oral it's a peanut oral immunotherapy, and then earlier this year, a second treatment has been approved, which is a biologic anti-IgE called omalizumab. Meanwhile, independently, are a lot of other things in development that have not yet been approved. And then also the rescue treatment for years. I mean, I'm old enough to remember an Anakit, which was a pre-filled syringe that was in a plastic case that had epinephrine in it, and you would just use that. We called it a bee sting kit or whatever. A huge innovation was the auto-injectable epinephrine devices, which began at least 25 years ago, and has evolved into several different types of products recently. And then in an exciting way, and Matt probably can echo this, that we've had patients that come into our office and they say, well, yeah, I ended up in the emergency room. And it's, well, did you use your epinephrine quickly after the symptoms began? And they said, no, I mean, I didn't. I just couldn't bring myself to use the needle. And so having some strategy other than an intramuscular needle in the thigh is going to be helpful for many patients. And there's both intranasal products being developed as well as, I believe, sublingual as well. So there are innovations in many different directions. Though I have to say, it's taking a while to get these things into widespread use by patients in the real world.
Yeah, the innovation and the development is remarkable. I'm old enough to remember an Anakit because I used to carry one for my insect sting allergy. But I'm young enough to remember a time when we didn't have very much to tell our patients when they were diagnosed. This even predated a lot of the labeling laws and things, and a lot of it was good luck and call us if something happens and we can try to sort of work our way out of it. Now we can sit down, and I have half of my schedule is booked up each week, which is specific hour-long consultations to go over what the options are. Because now you can tailor this. It's not quite personalized medicine yet, but you've got different options, different strokes for different folks in terms of a couple of different ways that are available to tackle the same problem, each that have pros and cons, but can really sort of be adapted to what the family wants and totally aligned with their preferences, which is wonderful. And the next thing that I tell them is not only do you have choices, but this is just the beginning. And if you don't like where it is this year, just wait a year. You'll see more options. So, the biggest thing that I try to urge my patients is we've got great options and you can jump in now. But if you're not totally sold on it, waiting another year is not that, you're not losing anything. And usually I make some joke about them. This isn't going to be why you end up in Columbus at Ohio State crushing beer cans on your head on Saturdays. The IQ won't be diminished. I'm a huge Michigan fan, and I say that with total unabashed enjoyment of my rival to the south there. But no, I mean, you don't end up missing anything by waiting to see. If the options aren't right, don't rush. The biggest risk is doing something because you feel you have to do it rather than waiting for something to be right for you. And again, the options are bright. We have at least 5 to 7 drugs in the near phase 2 to phase 3 pipeline right now. You've got epinephrine options that are there. So again, this is, well, we'd rather nobody be food allergic. This is a good time to be food allergic because there are a lot of options available that will really change the trajectory, I think, of not only the children, but the parents and the adults with food allergy. If they opt into this, can change everybody's life.
Well, as you point out, things have changed. And in some ways, it's hard to stay informed as physicians, as patients, as parents. So I wanted to ask you, all of you, what's the role of CME? How do you continue to educate physicians about these new advancements? And there's a lot going on. As you know, a lot of it is about the nuance, right? Exactly how does it work and who is it for, given the spectrum of food allergies? So what is that role of CME?
I can start with that and see if others want to chime in. I think it's critical. I mean, the more we learn, the more complicated it is. I mean, this is not understanding the data from the clinical trials that are done. As I mentioned, no hemoglobin A1C. We can't. There's no easy, uh, sort of outcome that is used from one trial to the next, other than double-blind placebo-controlled food challenge, which is an imperfect estimate of that patient's allergy. And even within the double-blind placebo-controlled food challenge, the outcomes vary depending on the protocol and the study and the company that's doing it. So I think um, simplifying the interpretation of these data that come out is really important, as well as understanding the variation and the heterogeneity of various food allergies. Now, one thing that Matt mentioned, which I generally agree with, as with most stuff that he says, was that there's no rush necessarily to run into a treatment that's imperfect. And I agree with that for most patients. The
Mm-hmm.
one exception would probably, that I would say, is in early in life, once there's what we call a phenotype that evolves, and in the first couple of years of life, it may be more willing to change. And this was brought forth by an NIH study called the Impact Trial, which is very interesting. And so I think in some cases, there may be a sense of urgency to at least think about treating, and therefore having the patient be evaluated by an allergist at a very young age if the history is concerning.
Yeah, I'll jump right in on that because I fully agree. I think now, right, you take a kid who's introduced peanut or egg or whatever for the first time, and let's say it doesn't go as planned, because again, there are kids that are going to end up allergic. We now have the ability to the next day or the day after. They could live literally 36, 48, 72 hours without an active solution to treating their food allergy. And what we can do is eliminate a lot of the doubt, the uncertainty, the issues that develop with quality of life and adaptation, all of that. We can give the kids and the parents taking care of those children a whole new trajectory to look at it. That there's, unfortunately, a whole generation of kids who didn't have that advantage, but we can correct that immediately. So yeah, I agree with Steve. If they're willing and able and they like the profile of what you're offering them, then yeah, I mean, treating those infants early on, and that's there are papers out there that even advocate for this approach that before you even do early introduction, you talk to the parents. If it goes wrong, here's what we can do so you can start them. And now with omalizumab is approved down to age 1. So again, even if they don't want oral immunotherapy, which you can do at any age, you got just a couple of months. So the gap is much narrower. And I think you'll see a whole different trajectory of empowerment from this generation that can start treatments early. And if you do it right, that kid will never know the difference that they grew up with or without their. I mean, they'll just see everything that they can because they'll be protected, and they'll have a whole different outlook on life, I think.
And I want to just add that life transitions is also an opportune time for a drug like omalizumab. Kids that are going away to high school or to college, it gives parents that extra sense of security. And, mark my words when I say food allergy impacts the quality of life.
Well, what's the role of the healthcare team? Everyone's not going to be able to go see an allergist that specializes in foods, depending upon where they live. Some people are going to see the pediatrician, some are going to see the family medicine physician, others are going to see the internist, others are going to see a nurse practitioner. How do all of these play a role in the management of food allergies as well as anaphylaxis?
Maybe.
This is where you need CME.
Yeah, well, exactly. That's what I was going to say. Is that disseminating accurate, peer-reviewed and evidence-based education, I think, is critical, and I think that's where the advocacy community plays a critical role. And there's a number of advocacy societies, including FAIR at foodallergy.org, that has a lot of resources. But I think, in addition, the MedEd community, where, for example, I think there's something like 75,000 pediatricians in the U.S. I mean, this is a lot more than we're going to see at a national meeting or and what have you. So the community that includes Medscape and other MedEd companies, I think, is critical to utilize online learning. But that CME accreditation, I think, is critical because there's this independent body that has basically control over it, and the ACCME is very serious about what they do, and so it's usually a way to validate that this is something that's believable.
Well, certainly educating physicians is key. Communicating to patients is key. Sometimes we're not always the best communicators. Sung, before you came on, I shared the story how my younger son has a peanut allergy. And no one really communicated to him that it's not a nut allergy, despite what the name says. So he often will still say he has a nut allergy. And technically he has a peanut allergy. We talked a little bit about cross-reactivity, but how do we become better communicators? I'd love to hear strategies from everyone because, in the clinical setting, people are rushed, right? We often don't have as much time as we would like. We want to guide people to the right sources of information. Sometimes they talk to other people that have allergies, and that's not always correct, what people say. So what's the one or two tips you could give to viewers as to how to be better communicators when it comes to food allergies and anaphylaxis?
2 words: plain language. I think sometimes we forget that we use a lot of medical jargon that may not resonate. And I think we have to talk to our patients where they are. Use terminology that's familiar to them, give them examples, give them reinforcement. So it's multi opportunities, something written, something that's a video, making certain that they hear what you're saying and it's reinforced by other methodologies.
The teach back is really important. That can eliminate a lot of the if you have them in the office and but I think plain language and recognizing that sort of reading levels are probably less than what we may realize, and sort of health numeracy or understanding sort of numbers and figures and stuff. There are a lot of people that we see who may struggle with this, and what's routine to us in communicating, you can go right over somebody's head, and that doesn't help either party. So like very simple terms, plain language. I think it's, but again, it's sometimes directing into other websites. This age is great for both information and for misinformation. And sometimes the misinformation leaves a bigger mark than the information, and you spend a lot of time sort of, it's a mixed bag. I'll take it because it's a step forward, because somebody can go anywhere in the world, can go online, they can look something up, they can find it. You said something about the legumes and the tree nuts and stuff. There's actually a great Wikipedia article on the derivation of tree nuts as Drupaceous fruits that honestly I learned something when I read that. So like you can go on and get this stuff, but again, careful. You got to make sure that you have a vetted source and stuff. And again, not every source is written at a great reading level. It can go right over somebody's head too. So it's a struggle.
Well, Steve, Song, Matt, I want to thank each of you for taking time today to work with us at Medscape, and Fair, certainly thank you, Song, to really combat misinformation and really to kind of help educate folks on what some of those new advancements are and what's on the horizon. And then how do we communicate that to everyone, not just our colleagues, but parents and patients as well. So thank all of you.